Good afternoon, everyone. Thank you so much, Elizabeth. Today we're going to focus on the Health First strategy around confidentiality, and I'm going to start by talking about patient consent and discuss the opt-in, opt-out modes, different opportunities for how to handle patient consent. We'll also discuss patient-level confidentiality, and I'll share with you the experience that we had at Health First in rolling out the HIE. First of all, what is patient consent? What are the essential concepts that you need to know when handling patient consent? Implied consent is authenticated and authorized users can view all patients. So that means when a patient registers, you're assuming that all of their information will be available. Opt-in is when the patient is giving their permission to be a part of the information exchange. They explicitly say, yes, I want my information to be shared. Opt-out is the patient explicitly asking not to share their information within the information exchange, and they will have their data hidden from view from providers. Patient-level confidentiality is when the patient can selectively restrict records from the EMR so that they are not able to be viewed. So what is consent? Patient consent is the act of the patient giving permission to opt in to the health information exchange, which we use DB Motion as our information exchange, or to opt out. Within DB Motion, at the patient level, the patient can consent to share their medical information or choose not to share it. Without confirmation of the patient's consent, the user cannot enter a patient's medical file. There is an opportunity where you can have an emergency declaration and you can break the glass and actually access the data against the patient's consent in emergency situations. Overall, the patient consent value is part of the IBM Initiate. We use Initiate as our EMPI, and it goes through the input stream, which means that the consent is at the patient level and not at the act level, so not at the individual data exchange or encounter level. Again, opt-in at the patient level, the EMPI will be marked with the patient consent, and any information that is related to that patient at the patient level will not be shared without the appropriate permissions. Or, again, if the physician and physician only can designate an emergency to break the glass. Opt-out, all the information at the patient level is shared and can be viewed unless the patient opted out, in which case their information, their chart is checked per se, and that information does not flow, so it is not visible to a provider. Most DB Motion clients will assume implied consent, and you have the option to do it either way. However, most of them will assume implied consent. Patient-level confidentiality, just digging a little bit deeper there. The consent is based on EMR capability to selectively restrict particular patient records. So again, it's not based on the DB Motion functionality. It's really based on your EMR functionality, in which you can restrict particular lab values. You could restrict particular encounters, like, for example, any psychological evaluation or psychological notes. That sort of thing could be restricted. The advantage is that the users can view the other patient records without being completely restricted, which is nice because you can sort of be able to decipher the information and still make readily available information that may be needed for patient care and good quality care without being able to see the things that the patient needs to have restricted. The disadvantage is that it currently can only be changed in the appropriate message received from the EHR. So you have to have the automation and the technology there to support that level of confidentiality. Patient-level consent, all data will be based on the patient's decision mode, implied consent, opt-in or opt-out. All data associated with that patient will not be exposed based on the patient decision mode. The patient-level confidentiality is that the set under the EMPI where the patient search page will receive the marked indexes, and based on the source system, patient-level response will display accordingly. I know we've said several things in the different ways to help everybody to understand the differences between patient-level consent, patient-level confidentiality, opt-in, and opt-out. So this is just a diagram showing the different options where the patient consent goes either opt-in or opt-out, and then do you use patient-level confidentiality, and then the yes, no, and then it shows you how either the entire record is not available, the entire record is available, or it's available with certain exclusions. So what did we do at Health First? Our initial rollout was that we had all patients during the registration process had to consent in. So it was an opt-in strategy. Unless the patient was able to consent at the point of registration, their information was not available. We really decided to err on the side of caution, and by doing so, it led to some unintended consequences. So let me tell you a little story about how this came to light for us. We did a visit to one of our emergency room departments and to talk to the staff and the providers regarding the use of HIE. This particular case was a perfect case where information exchange would have been very beneficial to the patient. And the patient had actually been a patient in our emergency department several times prior. But on this particular occasion, she came in and she was unconscious. Therefore, she was unable to opt in to the information exchange. And our registration staff, therefore, did not check the box to opt her in, and the information was not available to the providers. Our providers are very cautious of breaking the glass, and they did not feel that they necessarily needed to break the glass and create that breaking of the patient confidentiality without the patient's consent. Therefore, they did not, and the information was not available. So what we found was happening was that in an attempt to be cautious, in an attempt to be conservative in the amount of information that it was shared without patient consent, we really found that our providers were not able to access that information. Fewer and fewer patients opted in, and there was a lack of knowledge on the patients as well as the registration staff in terms of what that meant for the care that could be provided. So venues stopped looking when patients don't opt in and information's not there. They stopped looking in our HIE for any information. Some patients opted in during one visit but not another, and that created a lot of confusion as well. The registration staff was constantly changing that opportunity. The real need was not being met for the intended benefits of an information exchange. And the more we talked to the providers, we realized that was happening. So what are we doing now? Once we realized this, we have now changed our strategy, and we are now in an opt-out mode. So the patient has to make an active decision to opt out of the information exchange. We have changed our consent process to where I'm sorry, I just lost my screen. We've changed our consent process so that the patients can call a phone number or go to a web page where they're able to opt out of the information exchange. Otherwise, they are consenting to be included. We have just recently made this change. We did a lot of education with the registration staff, with HIM, and we had to put together an 800 phone number for the patients to be able to call to opt out, make sure the consent process was clear, and we are now in the middle of an upgrade for DB Motion, and therefore I don't have any metrics to show you, But our next steps are to be able to, one, go to the provider level and have conversation about how they're using the HIE now that patient information is being provided, and then really to find out what the usage is and how it has increased based on our opt-out strategy. We will be doing marketing and communications. As I mentioned, we found that our registration staff, as well as the patients, were not familiar with really what an information exchange means. We know they have asked for it because they don't want to repeat themselves. However, the wording and the communication around it needs to be solidified so that our patients and our own staff understand the benefits of an information exchange and why we went to an opt-out strategy. So marketing and communication will be involved in that as well. So I mentioned the next steps. We're doing the upgrade. We're going to monitor for adoption, continue to educate, and use marketing and communications in our strategy to improve the usage of the information exchange. And that concludes my story. I'll pass it back to you, Elizabeth.
Thank you very much, Carrie. We appreciate learning how Health First has approached it. It makes some sense to see if there are any questions specifically for Carrie Ryan on the Health First experience. One has come in that we'd like to start with, and that is, Carrie, if you could talk to us a little bit about the sorts of marketing and communication activities you think are going to be effective. And kind of a second question along those lines are, what are the messages and the value of information exchange that your patients are responding to?
Great questions. Thank you. So the marketing strategy that we're going to use is really to send out information to our customers, meaning our patients and our members, because we also have a health plan, and we have an ambulatory group. So we've got patients coming to us from many different angles. And we all know when patients come to the hospital and they're signing consent, it may be informed consent, but they're anxious, they're stressed, they really don't know a lot of what's going on. So we'd rather do proactive communication with them and help them understand what an information exchange means and how, so when they're sitting in their living room opening their mail, they can get some information, because we would like to send that out to our health plan members and our ambulatory patients before they become a patient in the hospital. So that's really one of our strategies, is proactive communication, and then providing a little bit better scripting for our registration staff. We did initially do that, but we found that they came up with their own, and we need to reinforce the fact that there are key words that patients need to know in terms of that we're going to be sharing their information internally with other providers who need access to that information. So that sort of segued into the second question, which are what are the things, the benefits, and I think really it is about helping them understand that it's providers who need access to that information. It's not all providers. We're not providing information to people who don't need it. It's intended to improve the quality of care and to streamline their care so that we're not redundant in services and in testing for patients, so it can streamline their care and improve quality. And that's what we're finding patients understand. They're very savvy today. They understand that they don't want to give us the same information 5 times, and they certainly don't want us to repeat tests on them that were already done in an ambulatory setting or vice versa. So I hope that answered the question.
I think that's very good. Thank you, Carrie. We'd like now to welcome Lorraine Fernandez to our virtual podium. She's worked for IBM as a global healthcare ambassador since 2010. She works with customers and industry groups to promote best practices and to design solutions that enhance patient and provider matching, as well as other domains of data, to support transformative healthcare initiatives. Lorraine has won state and national awards for her efforts to promote high data quality and standards to enhance interoperability and data exchange. Lorraine?
So in my role as healthcare ambassador for the IBM software group, I have the pleasure of working, as they shared, with health leaders in a provider, an association, and in jurisdictions, whether it's the States, Canada, or around the world. And as the slide shows you, and you can advance through this, what I hear uniformly around the world is that leaders are trying to address how to build a sustainable health system, whether it's financial or clinical, how to collaborate to improve care, and how to increase access to care. And as I said, it's uniformly around the world that I hear these objectives of what people are really trying to accomplish. So I'm grateful for being invited to this webinar series because it really illustrates these priorities that I hear. In particular, as you heard already, access to data, exchange of data, serving our consumers better is a key priority as we, as leaders, whether it's on a regional basis, individual provider basis, states, or even a federal jurisdiction, we're all marching to how to improve quality and improve access through data exchange, interoperability, and analytics. And as a part of this, the challenges are, how do we improve the quality of data? How do we improve access to that data? How do we understand the lineage of data as we begin to exchange from one organization to another, or perhaps it's even within a single organization? So as the next slide shows you, this may take the pathway of big data and analytics, and the area that I specifically work with a lot and have for the last 20 years or so is around patient and provider identification and the matching of that data. And whether you're talking about consent, as you heard earlier, or whether you're talking operational analytics, or perhaps you're an advanced organization that's really addressing big data in a Hadoop environment or other types of environment, many of these use cases require that you be able to understand who the patient or who the provider is within and across organizations in order to measure and act on population health, as the right side shows you there, or whether your use cases are around consumer insight and consumer engagement. And I would say whether you're a payer, whether you're a provider, whether you're a governmental jurisdiction, you're probably in some fashion addressing these use cases and addressing the need to understand, as I frequently say, who is Lorraine Fernandez, despite the variation of how my name may be spelled. My name happens to end with an S. My husband's Portuguese. 99% of the world thinks my name ends with a Z. And I have a very good maiden name of Grunewald, which no one could ever spell or pronounce. And obviously, I'm like other patients out there, other consumers. My data changes because I've lived in various places. And as I progress in a health system, perhaps today I don't share my Social Security number, but years ago I did, because I'm a bit more sensitive today to the privacy and security of data. So every organization is addressing this challenge in some fashion, and the foundation to all these initiatives, operational analytics, big data and analytics, or coordinating care, require that you understand who the patient is and where they have data. So as the next slide shows you, this might take the form in your organization of initiatives around care coordination, case management, data exchange and interoperability, and really addressing how you bring all of this data together. Because right now it may be sitting in silos within an organization. And so your first step is understanding who that patient or provider is, how to integrate their data within an organization, and apply the appropriate consents, as you heard earlier. And then march forward, perhaps to putting full-scale care coordination and case management together so that you can, in fact, begin the transformative activities in any given organization. And whether that's through accountable care organization, some formalized case management that used to be on an informal basis, or other types of initiatives. And as the next slide shows you, and we already discussed briefly, it is generally around population health and consumer insight that organizations are really putting their time and their energy and addressing the challenges that are surfacing in this process. I've worked with a couple of organizations, particularly in the last 6 months, who are getting what I would say is a major enlightenment, because as they try to integrate enrollment data or claims data from either their own health plan or some of the Blues plans, the Aetnas and the Cignas out there, it's really tough to understand who that consumer or patient is, given the data structure that varies so dramatically across all of these files that you may be addressing as you bring together care coordination, case management, and really try to address population health. And then in the context of that, make sure that you've got the right patient with their associated data. And obviously you don't want to assign patients to a case management or care coordination system who don't have perhaps the specific diagnosis that you're trying to address in that. Perhaps not a major harm if you erroneously assign somebody to a congestive heart failure program, but you can lose consumer credibility if you erroneously assign. And I say that with the assumption that the assignment doesn't necessarily include the clinical data, but obviously if there is major clinical data associated with the patient identifiable data, you then get into the area of concern about breach of confidential information and HIPAA compliance. So big challenges, and another reason that organizations are making sure their foundation of who is the patient, where do they have data, how do I integrate it appropriately, and then as you heard earlier, how do I apply consents as might be appropriate. As the next slide shows you, there was a couple of organizations here that we've worked with recently who are undergoing these major transformative analytic and governance plays in order to really gain the insight that they need to improve care and to reduce costs. And I know reducing costs is a sensitive topic that everybody is paying attention to, but it goes hand in hand with improving quality, reducing cost, engaging the consumer, and really providing better outcome that will hopefully drive down the cost of care in the U.S. And it's not that any organization is going to undertake these information governance initiatives and analytic initiatives as a big bang theory. They're perhaps going to do this incrementally. But if you're an organization that's already mastered your patient and provider data, you're obviously ahead of the game. And when you apply care coordination, to population health initiatives, for example, you've got that checkbox, you could say, already taken care of, saves you time, saves you money as you do your transformation initiative. The consumer engagement, the last point I wanted to address here, takes many different forms as the slide shows you. I've just highlighted a few here because consumer engagement might take the form of patient portals and kiosks that many organizations are dealing with. And it's interesting the slightly different conversations I've had with organizations as they embark upon patient kiosks, because the sensitivity about, am I presenting the right patient data to the right patient, and how do I ensure accuracy in that patient identifier so that I'm not getting into the territory of a HIPAA violation. So interesting conversation there. I also have conversations with some organizations around how to uniquely identify patients when it comes to meaningful use. Stage 1 and Stage 2 that we already know. And the NPRM that was released about a month ago, which begins to set the stage for even greater consumer engagement, a greater requirement around patient identification, and how we might standardize data to facilitate better patient identity. And you'll see that illustrated if you haven't read the ONC final report on patient matching and patient identification. If you don't have access to that, my email was at the beginning of this. You can ping me and I'll be happy to send it to you. And I've done a couple of blogs specifically about the ONC report to help organizations understand what it means to the future. Patient identification, standardized formats, perhaps prescribed field lengths and field positionings. So ONC and CMS are really charting a new path here, potentially. The last point I would make here is around what's the value of addressing patient identification and provider identification and enhancing interoperability of data. So this slide just shares with you a few metrics of customers IBM has worked with and the value that they've given, the results that they've gained that really help them achieve the objectives of improving quality and decreasing costs. And I think, as I said earlier, what goes hand in hand with that is better consumer engagement. And when I was working over the last few months with the ONC report and talking to customers, it was interesting to hear how much more emphasis providers and professional groups are putting on consumer engagement, and payers clearly are putting a lot more emphasis in that area also. So my closing remarks would be that addressing patient and provider identification and the matching of records across whatever your ecosystem is at a payer level, a provider level, a regional level, or at a federal level, that will have significant value to you as you begin transformative efforts. And I'm not implying it's an easy journey, because it absolutely isn't. And it's not a destination. It is a journey. But it's a journey that I think can reap high value to you and I as consumers, as patients, and really make the delivery of healthcare easier perhaps, certainly better, as we integrate data and think about how to build a culture, as the slide shares, that really embraces analytics, that supports making data-driven decisions, and last but certainly not least, along the way here, we have to discuss and act upon privacy, security, and governance, because those have to be integral in order to build trust with the consumer, with the providers, and then to ensure our regulatory compliance. So I wish you success on your journey, and that concludes my remarks.
Thank you very much, Lorraine. That was great to hear your insights on those issues. We have had a couple of other questions come in. One was a follow-up to the question that we asked Carrie Ryan a few moments ago. So Carrie, I hope you're able to pick up your train of thought. The question was relative to family members. You know, the example you gave with the emergency room, if family members in an opt-in situation are able to help make that break the glass decision.
That's a great question. I suppose that would probably be a decision more at the individual facility level based on their risk management and legal definition of the opt-in, opt-out. We certainly have had risk management and legal at the table because state laws are also need to be taken into consideration when you're dealing with the opt-in, opt-out. The break the glass at our organization is strictly left up to a physician provider. Even physician extenders are not able to break the glass. But I do imagine that should a conversation occur between a provider and a family member and the patient is unable to make that decision, do they have a healthcare surrogate who's making decisions for them, and then have that discussion where the physician provider feels more comfortable breaking the glass because the family member could potentially say, you know, I know that information, the physician has that information, or the primary care physician has that information, but I don't have it, you know, or says they have a long health history, but I don't know what it is. Those types of conversations, I can imagine, would make a physician much more comfortable breaking the glass. But we don't currently have in practice a defined strategy for involving family in that process. Great question. Good thought.
Thanks, Carrie. That's great. Another question has come in that the listener would like to have each of Lorraine and Carrie respond to. Lorraine, we'll go with you first. The question is, so much of patient engagement has been driven by meaningful use. How do organizations prepare for an expanding emphasis on patient engagement beyond meaningful use?
I think of a couple of things. Beyond what the government, in the context of the U.S., is promoting, I think when you build your plan for consumer engagement, patient engagement, I'd also think the patient groups out there, like AARP and other senior citizen and industry groups, and think about what they're promoting and why they're promoting and how they're reaching out to your community. Because I happen to live in Northern California, and I get a lot of marketing materials from my local healthcare providers, whether they're large IDNs or they're Kaiser or whomever, and it's very clear they're putting a high priority on consumer engagement, both from the payer, you know, the local outreach groups, and then their own market share activities and priorities. So think local and act local in that context. And, you know, maybe other ideas are be sensitive to what the schools are doing, the major employers are doing. So I would put that in my master plan of consumer engagement.
That's great. Carrie, do you have anything you'd like to add to Lorraine's response?
Would you mind repeating the question for me? Lorraine had such a great response, I kind of lost track of what the question
Absolutely.
was.
The listener wanted to know that so much of what we've done to date around patient engagement has been driven by meaningful use. And the question was, how do we prepare for the increased emphasis on patient engagement in a way that kind of goes beyond meaningful use?
Oh, yes, that's a great question. What I found is that in our discussions around patient engagement and trying to maintain scope for meaningful use, as we're implementing these different strategies and technologies that support patient engagement, I'm finding it actually easy to go beyond meaningful use, because to try to keep scope around just what we have to do versus what we really want to do, there's so much more out there. There's so much that we can do to engage our patients that really steps way outside the scope of what meaningful use is requiring. So I'm kind of having a hard time bringing us back to, let's make sure we get done what we have to do, and then let's add on the really cool stuff. And it's still, I think we can all say that patient engagement is still yet to be clearly defined. I think we all, every time we sit down at the table with different leaders and executives and clinicians, and then somebody says patient engagement, I say, time out, what do you mean by that? Because some people think, you talk to marketing and they think patient engagement is just getting them in the door. And then you talk to a clinician and it means patient satisfaction. And you talk meaningful use and it really means engaging them in their care beyond, just doing what the physician says. So there's just so many different aspects that we have to be sure that we've defined what that means for our organization, and then really look at what are our resources that we have to be able to do it beyond the walls of the hospital or the clinics. And I know that was a very philosophical answer, but I just think there's so much out there that when you really start to brainstorm with your teams, and your teams should include clinicians, providers, marketing, executives, strategy, all of those people should be at the table when you're really brainstorming around what patient engagement can be, and then set your priorities so that you're really doing things that hit the mark and are value add. There's a lot of things you can do that will not be value add, and you have to be careful.
Excellent. Thank you very much, Carrie.
Mm-hmm.
The next question, will we have a national patient identifier as part of the ONC activities? Lorraine, maybe you could answer that first.
Happy to. And this is Lorraine's personal opinion, plus a little industry perspective. The answer to the ONC part is no. When the ONC held their meeting in mid-December in Washington, D.C., Joy Pritz, who is the Chief Privacy Officer for ONC, stood up for about 5 minutes and said, guys, a national patient identifier to support healthcare is out of scope, off the table, move on. She did say that, biometrics as a way to augment patient identification is something that ONC will embrace. But because biometrics is just beginning to be adopted by healthcare, the ONC final report really didn't address biometrics in any major way. But it'll be a part of their future vision and future activities. So my personal opinion, I don't think we'll see a national patient identifier in the U.S. in my lifetime. And I've got a few decades to go yet. And even if the day comes when we do have one, and obviously many countries already have one, those countries in the U.S. will probably still use probabilistic patient matching because you've got all the legacy data out there that won't have a national identifier. And you'll have to link that to the new data that might have a patient identifier. So ONC's activities around this will march forward to enhance data quality and interoperability, but a national identifier won't be a part of those.
Thank you, Lorraine. Carrie, do you have anything you'd like to add?
No, I don't have anything to add to that. That was a great answer.
That sounds great. Well, it appears that there are no more questions in queue. We've reached the end of our session, and we want to express our appreciation to IBM for its sponsorship of this program. As I mentioned earlier, the presentation will be available on the Allscripts website, and that link will be sent to all attendees shortly. We want to thank all of you for participating. Thank you for your patience with our technical difficulties, and special thanks to both Lorraine and Carrie for their excellent presentation. Enjoy the rest of your week.